Good morning, everyone. Thanks for the committee of the NINT Congress of the APPGS Cebu, Philippines, who inviting me as one of the faculty. So right now, I would like to share to all of you about the surgical closure of the ASD in adults with a small size of the left ventricle. I have no disclosure. We know that atrial septal defect is one of the most common in the congenital heart disease, around 10%, and more number in adult congenital is around 20 to 40%, has a very minimal risk, RAS score only 1, and low mortality should be less than 1%, and also very short hospital stay after surgery is approximately 4 days. This is the physiology, pathophysiology. Mostly the problem is the volume overload on the right ventricle that can cause the pulmonary hypertension, especially in the late presentation. But we have to not to forget the left ventricle because it's underload and become the small in the future. Yeah, like this. So the volume underload can cause the geometric change of the left ventricle, and sometimes concomitant with the mitral regurgitation that cause a small left ventricle, and for the long term can cause the left ventricle diastolic dysfunction. Like this patient. So this patient, 18 years old girl with the small size of the left ventricle and also the mild mitral regurgitation, as we can see here, she has a huge right ventricle with a severe tricuspid regurgitation, huge ASD, and has a pulmonary hypertension. Yeah, tricuspid valve gradient 54. But the left ventricle is still good based on the left ventricle ejection fraction, 88%. So is it still straightforward case? Yeah. Stephenson et al. Already reported that left ventricle end-diastolic volume index and left ventricle systolic volume index in ASD patient was significantly lower compared to the healthy subject at rest. Yeah. What will happen if we put a patch on the ASD? So suddenly the volume on the right ventricle will be decreased. But we have to understand also the left ventricle will face a very huge amount of blood. Left ventricle volume will be increased gradually, and it can cause the acute left ventricle failure, and sometimes can cause the morbidity as well as the mortality. So we try to figure out how big is that the problem. So at the 2015 until 2016 for 48 population with the ASD and small size LV, we found that mortality increase, especially arrhythmia and low cardiac output syndrome, huge, 34.8% and 26.1%. So, based on the guidance of the European Society 2020, mostly based on the indication for the management of the atrial septal defect, indication for the closure, mostly based on the right ventricle volume and also pulmonary hypertension. Uh, for the left ventricle, only disease, it's not clear enough. So that's will be a question. Should we consider the left ventricle size on volume for indication for the ASD closure? So that's why we try to figure out by doing the retrospective cohort study on our patient, on our population. So the objective of this study is to evaluate whether the left ventricle end-diastolic volume index could be used as predictor of the low cardiac output syndrome after surgical closure of the ASD with small size LV. And also at the same time, we try to determine the cutoff value of the left ventricle and diastolic volume index. Inclusion criteria: the patient with ASD who underwent surgical, and also with small size LV based on the echo. The left ventricle should be less than 50% of the right ventricle chamber. And exclusion, we exclude the severe pulmonary hypertension. Yeah. This is how we did the analysis. So we try to find out the optimal cutoff for left ventricle and diastolic volume. Now, so this is the characteristic of the subject. So preoperative data, most of the patient similar between two arms with a low cardiac output syndrome and without low cardiac output syndrome. We can see here similar between these two arms. And also intraoperative data, almost the same between these two arms. Yeah, but postoperative data is different. With the low cardiac output syndrome mostly has a longer length of stay and duration of ventilation usage, and also has a more postoperative arrhythmia. And then the result for the MRI parameter and the occurrence of the low cardiac output syndrome, mostly the small size left ventricle, whether it's a systolic or diastolic volume, is significantly lower than the population without low cardiac output syndrome. So it's very different about the right ventricle. There was no difference about the size on the right side. So for the right side, the volume difference was not significant among these two arms. And from this area under curve, it showed that left ventricle and diastolic volume index is superior than others parameter. Yeah, this B, we exclude the patient, the population with the moderate to severe mitral regurgitation. So still the left ventricle and diastolic volume index is uh, significant, yeah, still high. So here we see that the sensitivity and specificity for the left ventricle and diastolic volume index is higher than others parameter. Yeah. And we found that the cutoff value is 53.3 milliliter per meter square. So for concept diagram for the this study, so we have 269 subject, only 57 patient with a small size left ventricle, and 30 patient is has less than 53.3 of left ventricle and diastolic volume index, and 27 subject more than that. We can see here mostly the patient with low cardiac output syndrome has less than 53.3 milliliter per meter square of left ventricle and diastolic volume index. So how about the population? How we manage the patient with a small size LV and also with severe pulmonary hypertension? Unfortunately, this patient has no MRI. We can see here the small size LV with the severe tricuspid regurgitation. We did the CAT study on this patient. We found that the pulmonary artery resistance index is 8.3, severe pulmonary hypertension, but still has a very good left ventricle function. Yeah, and also after oxygen test, the saturation still high. So what did we do on this patient? We did the ASD closure and leave the small ASD in order to decrease the volume of the left ventricle, yeah, as an escape. Yeah, and did the tricuspid valve repair. Yeah, there was no any tricuspid valve regurgitation anymore. And also we did the small left ventricle management. I will explain what is that the small left ventricle management. This patient spent 15 days in hospital. So this is our post-op experience. Most of the patient with the small size LV and pulmonary hypertension almost similar in the picture after surgery. So we did the diagnostic first, and then during the surgery we did the mild hypothermia and give a Miranon as soon as possible after pump on. And then during weaning CPB, usually patient will has a bradycardia and also increase in left atrial pressure. We put the arterial pace in order to to avoid the left ventricle distension, and put it on around 100 beat per minute, and give a maximum of mirinon, and also titrate the adrenaline. And then we transfer the patient to the ICU with a full sedated, full muscle relaxed, and also control arrhythmia. In ICU, yeah, we have to give the attention to the hypertension and also the left atrial elevation. Usually, it will be happen. Uh, we will to treat this by give the patient diuretic, yeah, negative balance, and then still use in POD1, still use the temporary pacemaker, 100 beat per minute, normothermia, and also arrhythmia we control as much as possible. Usually LR pressure will be decreased, but still hypertension. Sometimes already sinus rhythm, but still tachycardia. Usually POD2, LR pressure will be decreased. Yeah, and that time after echo evaluation, if everything's good, especially left ventricle, we will try to wake him up, and then POD3 usually we will do the try to wean slowly of the ventilator until extubation. And what is a small LV management that we do on those patients? We have to put left atrial monitoring, with or without small ASD creation, yeah, and also optimal afterload reduction, mirinon, start during the CPB, using the adrenaline and RR pace to avoid LV distension, and keep quiet over 24 to 48 hours after surgery. And regarding the pulmonary hypertension and also the mitral regurgitation, we divide it into three populations. The simple one is ASD, small left ventricle with pulmonary artery resistance index less than 5, with or without mitral regurgitation. It will do the complete ASD closure. Yeah, but put LA monitor and small LV management. How about if a pulmonary artery resistance index more than 8? So, but reactive oxygen test, so it will decrease less than 4 usually. So we have to left the hole in the center of the patch and did a priority for small LV management, and then followed by pulmonary hypertension management. And then how about the patient has the moderate MR, small LV, and also severe pulmonary hypertension? We have to do the repair, quick in, quick out, yeah. Left the ASD small, yeah, and then did the LM monitor, small LV management, and also pulmonary hypertension management. It should be high risk population. So this is our outcome before pandemic. We can see here for adult case, yeah, see the mortality is higher on a small LV, yeah, 7.9%, and also significant has a low cardiac output syndrome. How about during the COVID pandemic? Still the patient with small LV, yeah, still a higher mortality, and also has a more low cardiac output syndrome. As you can see here, the pulmonary hypertension still is a severe pulmonary hypertension. So, what is our recommendation? We should consider the LV size and volume on this protocol, yeah, especially for the small size LV. So the summaries is the best cut-off value of left ventricle end-diastolic volume index to predict the occurrence of the low cardiac output syndrome after surgical ASD closure is 53.3 milliliter per meter square, and also small LV management, yeah, to avoid the morbidity and mortality of the patient with the ASD and small size LV, and also LV condition and size should be considered as one of parameter for indication of ASD closure, especially in adult congenital heart disease. Thank you, Mabuhay. Have a good day.